Hey guys, and today we're going to discuss stress inoculation training as a treatment for dealing with cognitive stress, or a cognitive treatment for dealing with stressors. Now, I first want to say, I said stress inoculation training, but I've also heard it referred to as stress inoculation therapy. So no confusion there, but it's definitely abbreviated to SIT. So for the rest of this video, for convenience, I will refer to it as SIT. This is a study that you need to learn for the OCR A2A level psychology specification, for the options and applied psychology paper, and the health and clinical option. Now, as I always say in all these videos, you're probably getting sick of hearing it by now, but there are more tech videos to come if you're not interested in these videos, and I think they're interesting for anyone who is going to need to revise for this exam in the future, or indeed just anyone who might have an interest in the psychology. You don't have to be sitting the A-level psychology specification to find this interesting, so it's just for anyone in general, really. If I have to explain it to you guys, it also helps me to understand it, so kind of a mutually beneficial thing, I guess. Anyway, so today we're going to talk about stress inoculation therapy, and the study we're going to discuss compared it with systematic desensitization. Now, you might have heard of systematic desensitization before. It's also referred to as graded exposure. And what I think's a good idea is if we go through a little bit of background on what SIT and systematic desensitization are, and what the differences are, because there are some. Okay, so we'll start off with SIT because that's really the focus of this study, and as such it's the one I know most about. SIT has three stages. It's a behavioural technique, so it essentially says that we learn to cope with stressors, or indeed we learn to be stressed by the stressors. So they're both learning techniques. SIT and systematic desensitization are both learning techniques. And as I was saying before I interrupted myself, SIT has 3 stages. They are the conceptualization stage, and this is the stage where the patient gets to know the professor, and they go through in detail exactly what the cognitive thought patterns are that lead to that particular stimulus being stressful for the person. In a way that's very similar to cognitive behavioural therapy that we cover as part of the forensic part of the specification. So that's a cognitive component, and that cognitive component is what systematic desensitization is lacking. There's no cognitive component in systematic desensitization. It's all behavioural. So the 3 stages of SIT are conceptualization, learning of coping strategies, and practicing coping strategies. Now, those stages 2 and 3 are pretty much what makes up systematic desensitization. It's also called graded exposure systematic desensitization because the therapists gradually introduce the patient to situations that cause more and more stress. So it goes up in grades. They're gradually exposed to more adverse stimuli. That's why it's called graded exposure. So all you need to remember is SIT also includes a cognitive component called the conceptualization stage, where they go through with the therapist what causes the stress, and they try to correct the thought patterns, much like standard cognitive behavioural therapy. That relies on, and it actually very dependent on the patient having a good relationship with the therapist. So that's definitely what we're going to discuss in this study when it comes to evaluation points, because that's quite important. So we've talked about the theories, both systematic desensitization and stress inoculation therapy. Now we're going to get onto a sort of empirical study to back that up with, because you have to in the exam, obviously you have to back it with real psychological research. So in this case, that was conducted by Mischenbaum, or Mischenbaum, I don't know how to say it. And I want to say that normally I give you dates for these studies because obviously they were carried out on certain dates, and the studies were carried out at different times. The one that I've got on this particular set of revision notes that I'm looking at now is Mischenbaum 1972, but I've also seen the exact same study reported as being in a paper published by Mischenbaum 1975, and I've also seen it in as Mischenbaum 1985. So we're gonna leave off a date because I'm not sure. But what was the aim? The aim was quite obviously to compare the systematic desensitization group with a control group, and also with a stress inoculation group. Now, it's important to note that this is Mischenbaum's study, and Mischenbaum came up with the idea of stress inoculation therapy, as far as I know. So he's likely to be motivated to make sure that comes out on top. And when we talk about evaluation points, when we talk about bias, that is also something important to consider. The method was a field experiment conducted on 21 students between the ages of 17 and 25, and they were responding to our advert for treatment for test anxiety. So the stress response being treated in this case is test anxiety. It's worth noting again in terms of evaluation points that they're students, so that might have some issues with generalizability. They're of a certain age, so that might also have an issue with generalizability, and they're only testing people who have test anxiety. So these findings may only be generalizable to people who are suffering from test anxiety and not other types of cognitive deficits. That's often a problem with cognitive behavioural therapy. It works in in some situations for some people, but it's not generalisable to everything, and that can definitely be a problem here, and certainly with this study. So what was the method? Well, it was a matched pairs design with allocation to one of three groups. There were the stress inoculation group.
It's 14 hours.
In other words, the group that were getting stress inoculation therapy, or the systematic desensitization group, or a control group who were told they were being put on the waiting list. And in though it was an independent measure design, but it also had an element of matching to it. So it was matched pairs. So the groups were matched on gender and anxiety levels. So that's good because obviously gender could be a confounding variable. It could affect between the groups. So at least that's an attempt at control here. As always on matched pairs, there's very rare. It's pretty much impossible to match a pair on every single behaviour. So so there could be some control participant variable issues there that we normally get with independent measures. Also, it doesn't say here, but I'm assuming the only way they could measure test anxiety would be through self-report measures. So you've got some social desirability there. The people may not be in a test situation when they're filling in a questionnaire, so that might have low ecological validity. So we've got some issues there, but just some things to keep in mind. Yes, I was right. Each participant was tested on a self-report scale for test anxiety and allocated to a group, and it was random allocation, so minimal ethics problems there. In both the systematic desensitization and the stress inoculation therapy groups, the participants were given eight therapy sessions, and in the stress inoculation group, they were encouraged to identify their thoughts that made them feel stressed prior to the test, and sort of the therapists helped them come up with some more positive situations. So very similar to cognitive behavioural therapy, but just applied to stress here. Similarly, in the systematic desensitization group, they were asked to imagine progressively more stressful situations, and they were given coping strategies, told to practice at home, but there was none of this cognitive component, none of the relationship with the therapist saying identify your thought patterns before and after the test, and what do you think is wrong with the thought patterns. They were just given coping strategies. There was none of that component. That's the really important thing to remember in this study, between what's the difference between what's the difference between stress inoculation therapy and systematic desensitization. The difference is that systematic desensitization is just behavioural. There's no cognitive component there at all. I know I keep saying that, but this study clicked with me when I realised that. The control group were told they're on a waiting list and that they would receive therapy in the future. Some ethical problems there, treating some people and not treating others, but it was all randomised. So they did the best they could to get rid of that. Sorry about that, guys. The phone rang, so sorry for the awkward cut. As I remember before the cut, we just summarised the procedure, mainly that the two groups, the systematic desensitization group and the stress inoculation group, received 8 therapy sessions, and they were encouraged to practice at home, whereas the control group did not. That sounds like where we were up to. Now let's talk about the findings. Performance on the test, because this is about test anxiety, and they use the participants' average grade as a measure of, as one of the measures of whether the stress inoculation therapy had worked or not. Again, there might be some reliability problems there in this, some validity problems in that might not be a measure of whether the stress inoculation therapies worked or not, because they could have just done badly in the test, not because of stress, but because they hadn't revised well enough, or because of some other confounding variable. So that's definitely something to keep in mind there. But performance on the test improved in the stress inoculation group more than the other two groups. So Mitchenbaum's own technique has come out on top in his own study. No big surprises there. Obviously, he's going to be, and the people who are working with him are going to be good at implementing SIT, because if they're not good at it and they came up with it, then that's a bit of an issue. So there might be some biases there, but performance on the test improved in the SIT group above the other groups. However, they do say that the statistically significant difference was between the two therapy groups and control groups. So that means that systematic desensitization wasn't that much worse than the stress inoculation therapy group. So stress inoculation therapy isn't that much better in this study than systematic desensitization for treating test anxiety. Similarly, participants on the self-report measures of test anxiety, participants in the SIT group showed more of an improvement in their anxiety levels than either the systematic desensitization group or certainly the control group. They obviously, it's worth mentioning social reliability again here. I know I talk about that a lot, but it's definitely an issue here, because if someone's giving you help to try and deal with your stresses, even if it hasn't reduced your anxiety, you might say that it's reduced your anxiety because you don't want to look ungrateful. So there's definitely some social reliability issues there. But the conclusion, surprise, was that SIT was indeed a better treatment for treating test anxiety than systematic desensitization, or certainly nothing at all. But we must remember that the statistically significant difference was between both the SIT and the systematic desensitization groups versus the control group, not just the SIT group. So SIT isn't that much better than systematic desensitization for treating test anxiety, at least in this study. So we've talked about some evaluation issues, social desirability on the rating scales, so they might influence validity. We've talked about the fact that using test scores as a measure of whether the SIT had worked or not might be not a valid measure, because might not be measuring whether the SIT has worked or not. It might just be measuring how much sleep they had, or how much they revised the day before, or just their general intelligence level. So there's a whole bunch of compounding variables there. It might have some ethical problems, because you're offering some people treatment but not others, and pretty much you could argue this is a bit reductionist, because it's not. It's a cognitive treatment. It doesn't take into account the social aspects of stress, that you might be stressed because of social pressure that's associated with exams. Obviously, it's a big part of your life when you have an exam, especially at university level, as these participants were. So that's stress inoculation training versus systematic desensitization for treating test anxiety. Some evaluation issues for you there as well. Now, I do want to say that both cognitive behavioural therapy and systematic desensitization appear in the specification. Again, Bandura and Adams, 1997, used systematic desensitization as to help treat phobias of snakes, and they were measuring how self-efficacy affected whether that worked or not. So that in itself shows that there is definitely compounding variables there. And cognitive behavioural therapy, which is similar to stress inoculation therapy, although it's not just for stress, appears in the forensic strand of the specification, with studies like CAN 2006 and Friendship 2002 and 2003. So it appears in other places, but I hope that's given you a good description of the two techniques, and some of the study and some evaluation points to consider. So thanks for watching this video, guys, and I'll catch you in the next one. Bye bye.